Great. Okay, so hi everyone again, thanks for coming back. So this week I've been given the topic of delirium, which actually there's less slides than the last two ones, but I think there is still quite a bit to cover. So I'll just crack on really. I haven't got any cases this time though, I realise, but I imagine this is something that you guys probably come across quite commonly out of hours. So if you've got any questions or sort of cases that you found difficult at the end, then it might be worth us just having a discussion about those. So today we're just going to go for what is delirium, how to recognise it, the different types that there are, why it's important, what the causes of delirium are, investigations, and then probably management, which is probably going to be the main bit of the talk. So firstly, what is delirium? So it's a common clinical syndrome. So it's characterized by disturbed consciousness, cognitive function or perception, and the main part of it that has an acute onset with a fluctuating course. And then how to recognize it. So it's very much going into the definition. So it's an acute or subacute onset. I think one of the main things is that it fluctuates, which is unlike dementia. And then sometimes it's quite difficult to explain to relatives because sometimes they'll be absolutely fine and sometimes they'll be quite acutely confused. Impaired consciousness as well is another key element of delirium. And that can either be agitated or it could be sleepy and drowsy. Inattention as well. So this is the part where they sort of get a bit sort of fluctuating thoughts. So with inattention, one of the main things is in the part of the AMT is counting backwards from 20. And other ways of screening out is asking them to count the months backwards or sort of spell a word backwards, essentially. So disorganized and delusional thinking, which comes along with paranoia sometimes, and then hallucinations, which people might find quite commonly. Ultimately, that's a change in their baseline, so it's different to normal, which goes along with the acute onset. So it's important to get the collateral history in people who already have a cognitive underlying impairment. And then another thing just to point out, which I don't really know where it's not particularly in this recognition of delirium, but I just thought it was important to raise, which I'm sure most of you are aware of as well, is that sometimes people get really agitated and distressed with delirium, but if they've already got an underlying impaired consciousness, which means that they can't understand what's going on, sometimes these are just normal reactions to an abnormal situation. So, you know, when someone is acutely delirious and then someone comes along in hospital and is essentially telling them to stay where they are or is, you know, undertaking personal cares or toileting them, that's abnormal for them. So when you get that degree of agitation and distress alongside delirium, it's actually sometimes a normal reaction for them of what they're experiencing. So ultimately, I've gone too far. So the three types of delirium. So hypoactive being your sleepy, drowsy, not able to wake up. Hyperactive, your agitation, or acute, sort of when you say acutely confused, that's normally what we think about. And then mixed is, so it can fluctuate between the two, and you can get elements of the two associated with it. So I think one of the things is, why is it important, and why as geriatricians do we bang on about it quite a lot? So it actually is in the acute take presentations, it represents a third of presentations of older people. So they're older people who are coming in confused, but we take that as a new confusion or a new confusion for them, which would account to delirium. And it's actually the second most common presentation on the acute take, with shortness of breath being the most common. And I think that was pre-COVID as well. 1 in 5 patients in hospital are delirious, and that doesn't include people in IT or ED. Of those, 20% are delirium without dementia, but the rest 66% are dementia with delirium added on. And 1 in 4 people in care homes have delirium. So again, it's sort of tagged onto the bottom of the slide, but probably a theme that I'll run through is the diagnosis of delirium needs to be on discharge letters, and often we say they presented acutely confused, or acute confusion goes in as the diagnosis, and that's really not correct. It needs to be a diagnosis as a clinical syndrome, because people take sort of message to it a bit more, especially when people come back into hospital. If we see that they've previously been delirious on prior admissions, then it's a complication that we can expect to happen on their subsequent hospital admissions. So then going into that, so if someone comes in delirious or develops delirium during the hospital stay, then they are more prone to get other hospital-acquired complications. So that can be anything from falls, because they might get up and not know that they're unable to walk independently, pressure sores, and that can be from them, especially if they've got hypoactive delirium, they may stay in bed and not be able to get up for the period of time that they are hypoactively delirious. Dehydration's a key one. So for either hypo or hypoactive, they may not recognise the need to drink, be able to do it independently, or just are too drowsy to have any oral intake, and that means they can develop acute kidney injuries. And then that goes along with poor nutrition as well, so a similar premise, but they're not going to necessarily be eating as they should be, and they're going to develop sarcopenia and decondition really quickly. And we know older people do this, and especially if they stay in bed, which I think is the next point. So reduced mobility, even an older person staying in bed for a day can cause quite marked sarcopenia and deconditioning. And then they also have increased susceptibility to infections, again, especially if they're not as mobile as they normally are. And then going with reduced mobility, I think we think a lot of hypoactive delirium being a cause of that, but actually people who are hyperactive and agitated, if we think about the hospital setting, we try and get them to stay in their chair, stay in their bed, because of the risk of them falling, and actually they're not moving the way that they normally move. So taking from that, so they get all these hospital-acquired complications, and then from that, people are more likely to die. And some reports say that this is twice as likely. If someone develops delirium in hospital, they're twice as likely to die. You get increased length of stay because you develop all those complications, and then end up staying for potentially weeks longer than you would expect to. There's an increased incidence of dementia if you didn't already have it, that can be, so if it doesn't resolve, or people who do develop delirium, even if they haven't got a known diagnosis of dementia, may have an underlying cognitive impairment that was minor, but this has brought out a more diagnosable dementia, I guess. And they're more likely to be admitted into long-term care. I think in particular now with as much as the new pathways that we have to get people out of hospital, because we're trying to keep them out, get them out of hospital and out of those acute hospital beds, it means that sometimes, people are going for S2A, and ultimately a lot of the time they end up there and they stay there after they've been admitted to hospital, especially if they've had delirium. They're much more likely to be admitted to long-term care. And it's really distressing for the patients and for their relatives, because ultimately this is probably very abnormal to what their normal behaviour is like. So who's at risk? So really anyone over the age of 85, 65, sorry, that says. Cognitive impairment, people who have underlying cognitive impairment or dementia, and if they've had prior delirium. So that's why it's really important to have a look at prior discharge letters to see if they have had delirium on prior hospital admissions. Hip fractures are actually a really high risk of getting delirium as a complication post-operatively. And then severe illness, so any sort of severe infections, which will then potentially lead to delirium. So just a little bit on post-operative delirium, because it was a key thing on one of the lectures that I went to recently, one of my training days, is that often we don't consent for delirium when we are consenting for surgical procedures. And it's in older people, it's one of the most common complications associated with operations, and it doubles the mortality for older people. And in orthopedics, I think from studies that they've done, it's ranged between 12 and 50%. So people who get delirium post-operatively, which is 50% is a massive number. So then going on to causes of delirium, and these are the two acronyms that I think a lot of people use. So either pinch me or delirium itself. And I think it's important to sort of have a good idea as to what causes delirium, because ultimately it's going to help with your management. So if you have a little acronym to be able to work through, then it just helps you to just sort of think of your thoughts when you're seeing a patient who's acutely delirious and trying to think what the underlying cause is. So I think, I mean, in the delirium one, I don't particularly like the word restraints, but then when they're saying that, they're meaning it as in they've got sensory impairment. So either they've got hearing loss or visual loss, and that exacerbating their delirium, or they've come into a new environment and that's caused them to be delirious because they haven't got their other senses. And then metabolic is things like potentially like hypoglycemia, things like that. But yeah, I think otherwise it's fairly self-explanatory as to what may be causing the delirium. I think in the pinch me acronym, instead of restraints, they put environment as like things for like sensory impairment. So it's important though to also think about other causes of reduced consciousness. If you've got someone with either agitation or sort of drowsiness, just to think about what the other causes could be. So this is a general list of other things to think about. And I think the mainstay would be, especially for some of them, so like the psychosis or brainstem stroke encephalitis, is if they've got other neurological features, then it would definitely be something to think about. So not just the altered conscious level, but they might have some focal neurology associated with that. Also, encephalitis, you'd obviously be looking at your raised inflammatory markers in the context, I guess, of not knowing what the source of infection is, then it's something to consider. And then psychosis, I guess you'd be thinking if they've got sort of any psychiatric features, which is difficult because obviously in delirium we know people can get hallucinations. But I guess something more than what you would normally see in your normal delirium. So it's just things to think about, and sort of just maybe delving into the history a little bit more with the family, just to get a bit more of an idea about what might be going on. So some of these, so CJD and encephalitis in particular, you'd be thinking about lumbar puncture, and it's probably something that I think probably don't do as much as maybe. I don't want to say we should do, because I don't really want to be sticking a lot of needles in older people's backs, but at the same time, it's probably just something we don't necessarily consider. And even if you consider it and decide not to do it, we probably don't consider to do it enough, I would probably say. So investigations wise, so this is more to do with sort of probably recognition as well. So the 4AT is the sort of best validated tool that they have for delirium, and you can see the specificity and sensitivity there is in nearly 90 for the 4AT. And I think definitely in orthogeriatrics, I've seen it stuck in the notes. I think it's what we use in the trust as well for delirium screening. Other ones that you might have heard of, I think it can be used, but just generally the 4AT is just deemed to be one of the better ones. So again, as I say, like inattention is probably one of the key aspects of delirium. So even if you can't do a full 4 question, then sort of getting people to count backwards from 20, or count the months backwards, or spell a word backwards, or just think about their level of consciousness is sort of just a good screening tool to determine whether someone has delirium or not. The SQUID is this single question in delirium, which is really people just seeing someone and thinking, is this person more drowsy, more confused, more agitated than they were yesterday, and why is that? And investigating for the cause. So a lot of it is going to be back when we discuss the causes. That's what you're going to be looking for when you do your investigations. So it's working through your acronym and thinking what investigations you need to do. So I didn't really want to write another big list here, but you know as well that, you know, in on the frailty unit, everyone essentially gets a delirium screen when they come into hospital, because the frailty unit, when they've done their work sort of developing that unit, they determined that actually ensuring that everyone's got hematinics, everyone's got a CRP, everyone's got a calcium done was important in NLFTs, was important. So there's the nurses on there add them on. If they haven't been done, they look and add those bloods on. to people who are admitted to the frailty unit, and it means it's there for everyone when the post-take is done. The other thing to consider is obviously Nazia, have you got a question? Sorry.
Laura Wright can't see the presentation.
Oh, can everyone else?
Yeah, I can see it, yeah.
Yes. Yeah, I can see it.
Yeah, I can see.
I can see it as well. She's just saying she can't see it.
I'm sorry, Laura, I don't really know what to do about that. Maybe if she goes out and comes back in again.
Yeah.
Okay.
So the next part would be thinking about whether a CT head is needed for these patients. Now, I think, again, it's all very patient specific. So if it's someone who is young, I would say, and has come in with an acute delirium, then probably yes. If it's an older person, then I think you now need to start thinking about have they had a CT head done recently, which would potentially give you some answers. Do they already have a diagnosis of dementia? Is there any localizing focal neurological signs, in which case then you would need to do another CT head, because that could be the reason why they're acutely confused. However, if you've got someone who quite clearly has an infection and a source for that infection that isn't their brain, then I don't really see a reason why you would need to do a CT head, because that is likely the reason why they're acutely confused. However, if the confusion doesn't resolve somewhat, and again, I'm putting a bit of a caveat on that because we know that delirium can linger much longer than their illness, then it may be worth considering a CT head, especially if they've not had one previously and they don't have a diagnosis of dementia. Some of that is because in the future, if their delirium doesn't resolve, then they're going to potentially need psychiatric follow-up to review them for whether they do have an underlying diagnosis of dementia. That is part of the workup to ensure there's no underlying organic cause. So sometimes it's just thinking about why you're doing it and the specific reason. Obviously, if someone's fallen and hit their head, then that's another reason to do it, because it's potentially an intracranial cause, but for them to be confused. But it's very much looking at the history, looking at the results you've got. Do you have a reason why this person is confused? Is it related to their brain, or is it related to something else? But then I would say if it's not resolving, then they would need to have a CT head done in the future. So then going on to the management. Now, this is where it gets a little bit tricky, because there isn't really great evidence for management of delirium. So you'll get a copy of these slides when Nazia sends them out, but this is probably one of the better, if you want like a pathway. The link that I've put there, the Scottish Delirium Association, is one of the better pathways, and there's about 4. There's like a comprehensive one, a summary one, and I think there's another one as well, links on that website, and it's maybe worth just having a little look at those. So, and like it shows there that there's only really, when I went to a lecture last year, they presented there's only 3 randomized control trials into treatment of delirium, I guess because it's quite difficult to do a trial into that. So everything that we say is not really evidence-based, because there hasn't been that kind of scientific research into it. So one of the things is obviously prevention of delirium is key to begin with, and then communication, I think, is one of the other parts. So we need to be able to recognise those people at risk. So I'll just let Laura back in. We need to recognise those people at risk of delirium and then try and prevent that from occurring. So people who have the underlying cognitive impairment, those who've had surgery, and then communicate that risk to the patient and the families. And this is something that I've learnt more since doing orthogeriatrics in the last couple of months, is actually even before people are getting delirious, we are telling families and the patients that they are potentially high risk of getting delirium and what that can cause, to, in particular, to their length of stay and even their mortality. So they do suggest that we try and screen regularly, and the aim would be to detect 100% of cases of delirium. So the News 2 now has a level of consciousness. I'm not entirely sure how well that's complied with. because it's difficult in regards to people who are normally confused. So it's very much needs to be used as a new confusion, but then it sort of gets a little bit fluffy because there's not a way to input that into the chart when someone's already confused, but then there's a new confusion on top of that. So that's why the nursing staff are concerned, quite rightly. You can do the staff squid. So when people are going around, so 2 to 3 times a day, thinking and documenting, is this person more confused? Is this person more drowsy? There's a delirium observation screening scale that I've not really seen before and not really used myself. And then radar, which I'm now trying to think what that stands for, is something like acute delirium recognition. That's it, recognition of acute delirium, I think in your normal routine. So it's things like during drug rounds, and there can be charts for this. So when people do their drug rounds, they mark on the chart, and there's 3 questions, I think, and they go along the lines of, is this person more confused? Is this person more drowsy? And then if delirium does occur, then it very much is an individualized treatment plan, because people's delirium are caused by different things. So you are treating the potential cause, and then you're treating the complications that come from that. So people will get different complications from delirium compared to others. So it's very much an individualized treatment plan around what the cause is and what you think are the high risk of complications that they may get. Ensuring we communicate with the families, ensuring we communicate in the notes. So it's really important to document what your thinking process is behind this, and then communicating with the GP on discharge to ensure that they have appropriate follow-up in regards to that. So this, again, I sort of pulled this a little bit from a talk, I think it was from a psychiatrist actually, at one of our training weekends, and he used this thing called the Delirium 8, which when I was going through my notes, I couldn't quite work out all the 8 bullet points, but I've done sort of my own version of it. So the first thing that they suggested was the A to E assessment, because sometimes delirium actually is because there is a life-threatening thing going on underlying. So if someone has really poor blood pressure, then they've become hypoactively delirious, but actually it's because they're not perfusing their brain. So, it's doing your comprehensive A2 assessment first as best you can. And of course, if someone is, acutely agitated, and it's difficult to do, but doing what you can. And then identifying and treating the cause and optimizing, they say, condition for brain recovery. So this is sort of pointing out that less than 50% of deliriums have a single cause as the underlying cause. And it's thinking about, hypoxia, I guess hypercapnia would go along with that if someone was COPD, their blood pressure, glucose, infection, hydration, urinary retention, constipation, etc. And then thinking about minimizing psychological stresses alongside that. So that could be, is a cannula really indicated at this moment in time? Yes or no? Is the cannula going to exacerbate their already ongoing agitation? Is it safe to put a cannula in? And sometimes it seems really laborious, but all those sort of things do need to be documented in the notes, because when it comes back, why was this person not cannulated and have IV fluids? Then you need to be able to say, well, this was the reason why, and we did it in their best interest. And that goes along with catheters as well. So obviously urinary retention is a difficult one, because that is the underlying cause of delirium a lot of the time. However, would an ISC be better rather than a full-on catheter initially, because they're more than likely to pull the catheter out or become very agitated with the catheter in. If not, if catheter's what's needed, that's fine. But again, it's just making sure we've got that underlying thought process going on as we manage these patients. And then all about the environment. And I think a lot of the time when I was in medical school, that was sort of what we were taught about delirium. You need to be in a nice bright lit room, and you need to have a clock, and you need to have a calendar, and you do need all those things because people need to be orientated to where they are. But at the same time, it's much more than just that. And I know in a hospital environment, a lot of the time we can do the best we can do, but some of those things aren't achievable. And we can do what we can. I think there are some wards. I think in Newcastle there is a delirium ward where I think there's only 12 patients on the ward, but they all have a side room. There's enhanced nursing staff on that ward. And it's a great place they identify people who have delirium and bring them to that ward, which is brilliant. But at the same time, not everywhere has that. And the main thing with drugs is also just thinking about whether it's withdrawal from drugs or alcohol, rather than an actual drug that's causing it. So the other thing is, are there any psychotic features? So try and ask the patient specifically about whether they can see or hear anything that we can't see or hear, because that's an important feature to, because that might be what's distressing them in particular. Some people really don't care, and you ask them, they say, yeah, I saw a bunny the other day, but it was fine. But it's just knowing. So then going on to detect and treat distress and agitation. This is probably more where people get a little bit concerned about medication management. So in the NICE guidelines, if people are distressed or consider a risk to themselves or others, and then verbal or non-verbal de-escalation techniques are ineffective or inappropriate, so that includes non-pharmacological techniques, which we've already been through, you can consider giving short-term medication, usually for a week or less. Now, this isn't including in sort of that rapid tranquilization for someone who's acutely agitated and is, trying to harm people themselves on the ward. And they're suggesting haloperidol as first line in the NICE guidance. But what you'll come to see as we go through the next couple of slides is actually there isn't any evidence either way. For either of them, and for lorazepam or haloperidol. And really, it's just, again, thinking about the underlying reason that you're using it and what's safest for the patient in front of you. So then there's advice to start the lowest dose and titrate up as needed. So then we're going into which medication to use. So sometimes the other things just to think about is, why are they agitated? Is this because they have got features of psychosis? So are they really paranoid? Are they hallucinating? Where an antipsychotic is probably going to be the best choice of drug for you there. Or is it because of anxiety, where actually a benzodiazepine in a low dose might be the better option in regards to managing that acute agitation? So start low is always a key thing. And then I put slowish, because sometimes when you do give the lowest dose and the person is, 95 kilograms, then, a 0.5 dose is probably not going to do very much. But at the same time, it's probably safer to give a 0.5 dose and then give another one not too long after, rather than giving them the full whack in one go. But obviously, if they've got a low body weight, which a lot of frail older people have, then, lower and slower, the better. Please don't use antipsychotics in Lewy body dementia or Parkinson's disease. Otherwise, Chelsea Doughty, one of the regs, will come and find you and hunt you down. They cause, obviously, exacerbation of the extrapyramidal signs, and can really cause people to then have really prolonged course of length of stay, and really it's really detrimental to their health and their care. It's always worth, if you are going to prescribe haloperidol in the acute setting, just to have a quick look in the notes to see an ECG. I would even say it doesn't even need to be in the most recent admission. There will be one of the notes somewhere. Just have a quick look to check that they haven't got, a prolonged QTC or some other, reason why they're going to go into arrhythmia with it, just so you've thought about it more than anything. And ask for help, especially if people, you're assessing someone who thinks of risk to self or other people. If you're getting to the point that they're on more medications, especially if you're thinking that you've already prescribed, haloperidol, and you're going to give a bit of lorazepam, ask for help in those situations. If the diagnosis is unclear and if you're worried, just call someone, even if it's another colleague, because sometimes, you just need someone else to talk through, because you are ultimately making a best interest decision at that moment in time, and having another opinion is never a bad thing. So this is also from the Scottish Association of Delirium Association guidance, from one of the other charts, and what they suggest to use. So ultimately, if preferably, you would always want to try oral medication first. And in this guidance, they are suggesting haloperidol as the first line again, or an atypical antipsychotic such as risperidone. Now, I think risperidone technically is only licensed if someone has Alzheimer's dementia and then develops delirium on top of that. However, you will find that the psychiatrist will use it out of license and it will be commonly used off license. But I guess if you're not sure, for that out of hours time and practice, when you're not, especially at night time, when maybe you haven't got that access just to have a chat with one of the psychiatrists over the phone easily, then haloperidol is fine. But even on, Saturday or Sunday days when you guys are working, then I would consider just having it, if they can take orally, to maybe just having a chat with the psychiatrist on call to see whether something like risperidone or even quetiapine would be a better choice. Especially in quetiapine, they'd use a lot if someone has got some more psychotic symptoms, sort of paranoid delusions. I think they'd use quetiapine more. And then if oral is, you're unable to give oral, then to consider IM. And again, just starting low doses of haloperidol or lorazepam. When it comes to this out of hours at night, I tend to only prescribe a stat dose, and I might prescribe a second 0.5 for an hour or so down the line, or a couple of hours down the line, depending on their body weight and their risks, for the nurses to use if needed. But I never really want to prescribe this as a regular thing, PRN, especially IM, because it shouldn't really be used outside, an advanced care practitioner or a doctor saying that it's an appropriate thing to be using. We should be establishing people on oral medication and be giving it covertly if it's needed as a long-term basis, rather than that sort of PRN. And then this is the other guideline that I found, which is interestingly that they've developed it for COVID-19, and I can't find one for not COVID-19. So this is the Royal College of Psychiatrists. And actually, it's pretty comparable to normal day-to-day, I would say, when I've read through it. The only thing that I've cut off at the bottom is, so if you do want to go on the link when you get it, is it says how all the medications react with COVID-19 medications, so like remdesivir and all the other things that we can potentially give for COVID. It just says how they can interact, which I think is why they've released it. I guess in COVID, the other thing they've pointed out is, because lorazepam can cause respiratory compromise, then maybe lorazepam's not the best choice in someone who has COVID-19, which is fair. But ultimately, it says right at the top that there is an ongoing debate about what should be used first line, and you can pick either lorazepam or haloperidol. But saying that benzos in the context of COVID-19 could cause respiratory distress, so maybe haloperidol might be preferred. So again, this is more to do with sort of that acute phase, and then it's considering what we're going to be using longer term afterwards. And I think it makes the point in there as well that risperidone is mainly licensed in Alzheimer's dementia, but it gives you sort of a bit of an idea of, especially if prescribing it regularly orally, what the maximums are and what the time frame between them is that you can use. So the other thing to think about, obviously, is if you're doing this, is thinking about the legal aspects of it. So if you have someone that you are about to give sedative drugs to that does not understand the reason why you need to document a capacity assessment, and it's something that often isn't done and is really not good practice. So the problem is that it's time consuming. So remember that it's time dependent and decision dependent. They need to document that they don't understand what the decision is, essentially, or understand the aspects behind the decision making. They need to be able to weigh up the risks and benefits of that decision and retain that long enough to do the weighing up, and then they need to be able to communicate it back to you. If that's not the case and you're going to be prescribing these sort of medications, again, we need to be thinking about doles being put in place. Part of the doles paperwork states that, have you spoken to the next of kin regarding this, or someone to discuss in their best interests? And again, I think that's one of the things that often isn't done. So we need to make sure that we're also documenting the best interest decision-making aspect of what we're doing. So, call your colleagues, get another opinion, discuss it with the ward staff, which sometimes we know out of hours can be a little bit hit and miss because, ultimately they've called you for sedation in the first place. So but you know, in a best interest kind of manner, discuss it with the ward staff and call the family, because you know they have a right to know what's going on. And also there may be a lasting power of attorney lurking somewhere that you're not aware, no one is aware of, and no one's asked the family yet about. So you know, it's something that it just needs to be thought about. But this stuff takes time, and it's a problem on a busy night shift that people don't do it. But I think in particular, when you're working on your Saturdays and Sunday days, there's no excuse really that these shouldn't be put in place, and that we shouldn't be calling the families in particular in hours. So even if something happened overnight, we should be following that up in the day to make sure that everyone has been discussed and the best interest decisions have been made and put in the notes. So going back to the delirium 8 that we sort of did, that was all 4. So 1 to 5. So preventing complications, which we've been through. So it's just keeping them all in your mind. So again, it's thinking about, I think dehydration and malnutrition is really difficult, because you're thinking then about, does this person need IV fluids? Does this person need, how are we going to optimize the nutrition? So in nutrition, sometimes it's a lot of just ensuring they've got supplements prescribed, to ensure that you know, we're trying to optimize this as best as possible. Hydration wise, then we are potentially thinking about cannulation, you know, and IV fluids. But if that's going, I think that's mainly a lot of the time for people who are hypoactive delirium, that it's not going to cause them any distress. If they're extremely agitated, then it's a matter of trying to ensure that they maybe have someone encouraging them to drink when they're at their better times. Also, if we have decided to prescribe longer term sort of medication in the short term to try and help with their delirium symptoms, then you know, discussing whether that's something that could be given covertly under a deprivation of liberty and a Mental Capacity Act. But again, that would all need to be discussed with the family members. I think the other thing when it comes to medication, because that's often what happens with non-compliance, is just having a look down and thinking, what does this patient really need and what do they not need? They do not need their statin for a couple of weeks. They can get away with that. They don't need their Radcal for a couple of weeks, their folic acid, if they're not deficient, you know, all those sort of things. Just have a look through and think, you know, what can I do to make this better for this patient, that they can take the medications they actually need, and it would be easier for them to take. So like we said, communication with the patient and the carers is key. And then monitoring for recovery. So persistent delirium is delirium that hasn't resolved by 5 days, which is actually probably quite common. And I think communication with the family that in particular, that a lot of the time this is something that's not going to get back to normal, and sometimes that's because of the delirium itself, but sometimes it's because of the complication of deconditioning as a result of the delirium. And you know, the patients aren't going to be what they were before they came into hospital, and may never get back to that point. And it's a really depressing conversation to have, but I think something that really needs to be spelt out to relatives sometimes, because especially at the moment when they can't come and see their relatives, it's really difficult to try and convey over the phone how different they are from what they were like 4 weeks before they came into hospital. And now, you know, after their 5-week stay and they've had delirium, they've been deconditioned, what they're like now. If delirium is persistent, think about sort of getting old age psych involved, liaison, because they can provide supported discharges, and they can sometimes advise further on medication, particularly if it's agitation, that's or sort of psychotic symptoms that are part of their delirium. But yeah, it's quite a sad statistic. I think their recovery or partial recovery is 50 to 70% and can take 3 to 6 months, which is a really long time. And that's also suggesting that there's a large proportion that don't recover. Again, I think they're saying there's very few studies into this. They suggest that the median length is 3 days. I think that's quite quick, actually. I think it's probably much longer, to be honest. And then follow up, because a lot of people may have an underlying dementia, so ensure that it's communicated to the GP, and then also follow up with old age psych liaison, in particular for supported discharge if needed. So then probably take home messages from today is that delirium is incredibly common. We need to recognise the severe impact it has on our patients and try and reduce those complications as best we can while they're in hospital. recognition is really key, and making sure that we diagnose it as delirium. Management of delirium, I've just put management because it's just such a big topic, but prevention is probably one of the main things, and then managing the complications. And I think just ensuring that you are doing everything legally to the best that you can do, ensuring that everything is communicated and documented really clearly in the notes. And say, it's unfortunate that it does take a long time, but it's really important to cover yourselves as well as ensuring that the actions that we're doing are in the best interests of the patient. So has anyone got any questions on that? You can put it in the chat or speak up, I don't really mind. Nothing?
To say about sorry, like with hypoactive delirium, and I think they drop their GCS. So we've been to a few of them recently, and I just find them a bit daunting when you're thinking like with like CT heads and stuff like that. But obviously, you're saying if there's like obviously a clear source, then okay.
I think if there's a clear reason, then I wouldn't necessarily be doing a CT head. And if in your neurological examination, I know it's difficult when they're hypoactive, but if their planters are down going, they haven't got one going up, normally you can get them to withdraw, I find, from pain, can't you? So you can tend to assess their power in their arms and their legs. Yeah. So, from that side of things, I think if there's a clear underlying reason that, it's quite clear there's an infection going on, then I wouldn't necessarily be scanning their head, no. Cool. Anyone else?
Can I just ask Natasha, what is the final putting the dolls in? What are the requisites for that as a final requisite?
So when you should be putting it in, you mean?
on a night shift, say, for instance.
To be honest, you should be putting it in if you're doing anything that if someone, it's one of those things, if someone is trying to leave, trying to get out of bed, and then you are having to even putting it, really sometimes even putting a catheter in, or putting a cannula in against their will because you're restraining, giving some restraint to do it, you are depriving their liberty at that point because they're quite clearly trying to leave. I guess it's more so for the people who have hyperactive delirium than hypoactive delirium because you're not sort of restraining them or monitoring them, putting a one-to-one care in, for someone to stop them from leaving. Where the hyperactive deliriums, if you think a lot of the time you have a support worker, whatever, sitting there watching them, telling them to stay in bed, then you are depriving their liberty there because you are applying some restraint in a sense. So I think it's anything along those lines. I don't think hypoactive delirium, you're not really doing anything, from that side of things because they're not sort of, trying to leave, but you need to make sure again that best interest decisions are being put in the notes because you are doing treatment where they can't consent to it, essentially. Okay. So I think the dolls are more for the hyperactive trying to leave, and anyone that you're having to put enhanced care in, then I would be considering putting a dolls in place.
Great, thank you.
Lovely. All right, well, thanks everyone for coming again. I think some of you guys are presenting next week. Is that right?
Yeah, myself, Jo Piggott and Sarah and Helen.
Brilliant.
And Laura Wright will be doing a case study as well.
Okay.
So 15, 20 minutes each or something, depending on how questions and answers. So you have a break next week.
Brilliant.
We'll do the preparation.
Lovely.
Thank you very much.
I'll send these slides to Nazia again.
Yeah.
But yeah, so thanks everyone for coming.
Thanks, Natasha.
Thank you. Thank you. Thank you.
Thank you.